thank you so much for joining us.
Oh, thank you.
I would like to just kind of level set first. Do you mind introducing yourself briefly and telling us a little bit about the Houston Methodist ACO and all things that you lead over at Methodist in the value-based care and population health realm?
Happy to do that. Happy to be here. Thank you so much. So I'm Julia Andrini. I'm an internist. I am the Senior Vice President for Population Health and Primary Care and the founder of our Medicare Accountable Care Organization. And I have the privilege of working with what I call the dream team because we have a team approach. We have analysts, nurses, social workers, population health advisors, and collaboration with 300 primary care physicians. We take care of 50,000 Medicare traditional fee-for-service patients. Our whole goal is highest quality, 90th percentile, while saving costs. We take financial risk, which means if we achieve those goals, we receive 75% of the savings. And this was a milestone year for us. We received $50 million for our work, and we had a score of quality of 96.4. So super happy.
That's incredible.
And it's a team approach, a total team approach.
I think that needs a little round of applause. So that was your easy question. And now we're just going to dive into it, because why not start with the question we're here to talk about, which is value-based care now an irreversible economic reality, or is fee-for-service still winning?
Great question, great question. So most of the country, and Texas and Houston also included, is in a fee-for-service world. More than 50% fee-for-service everywhere. But every person, every healthcare organization, physician organization, they're all on a journey in value-based care. And why? Because of the rising healthcare costs. It's unsustainable. It's unsustainable. And a simple way to think about this is the payers are paying for healthcare differently. So would you rather pay for volume, how many patients you see, or would you rather pay for quality outcomes, how many of the patients you saw, you actually control their hypertension, you control their diabetes, and that's the shift to value. So payers are starting to make that shift, so we have to learn to do this well.
Yeah. What do you think, when people think about the pace at which we're moving towards value-based care, what do you think those who aren't in it are missing about kind of how quickly we may or may not be getting there?
I think it requires investment in infrastructure, requires a lot of technology, predictive analytics, and some people don't have the resources to do this well or start the journey. And most of the value-based care contracts are moving toward taking financial risk. So that's somewhat of a barrier too for people taking the financial risk. The pace has been slower than people predicted. And I think part of it is it requires infrastructure. It probably takes 3 years to break even, and also technology to manage large populations.
Yeah. Well, and just building off of that, when you're thinking about, so now you've entered a value-based contract, you need to think about, you've decided you're an organization that's going to take on risk. You need to think about which populations you want to do that for. So as Houston Methodist is thinking about, yes, this is a population it makes sense to pursue a risk-based contract in. Nope, this one, not the time to do so. How do you think about those decisions?
So the very first contract we did was with Medicare in a Medicare Shared Savings Program because it was the only payer in 2017 that would do a contract with us with financial risk at that time. So of course we went with that one. But to answer your question, we could not do this work unless we had all the claims data that was so that we could find opportunities to reduce costs and improve quality. We need all the claims data, we need all our EHR data, we need zip code data, This gets more and more sophisticated behavioral health, so if we can't get that data, then we're not able to move the needle. And the second population we're taking care of is our own employees. Because we're self-insured, we have the data, so we're able to do that.
Yeah. Well, and of course, I would imagine entering into those risk-based contracts with the payer, whether that's Medicare or others, helps open up some of the data that they have access to provide you with some of that, but I imagine not enough, which leads me to my next question, which is specifically about data. So as you take on a contract and you're starting to manage populations, you need a lot of data, and there's a lot to unpack there. If we start with, I imagine there are both more real-time signals you look at and also more retrospective metrics that you're measuring. If we start at the higher level with retrospective metrics, what is it that you're tracking towards? What's the data that you're looking at to say, is this working?
Okay. So retrospectively, any intervention we do, we're measuring the outcomes of admissions, readmissions, ED utilization, that our team may do an intervention, and have we reduced that? But have we really reduced it, or is just the complexity of the patient? So then we use a digital twinning process. We take these patients and they're matched to exactly the same type Medicare patients, and what is the expected? So what's our outcome retrospectively compared to the expected outcome from the digital twin? And our goal is always to beat the expected. And if we didn't, then we know, okay, why did this not work, and what do we need to do better?
That's fascinating. I have so many questions about how you are doing that, which I will ask you about later. But if we think about kind of moving from the retrospective piece to thinking about, we have so much ability now to look at real-time data. Are there any real-time metrics you're using, and how do you balance kind of the real-time data that you could give physicians access to make decisions versus what might be too much?
That's a great question. So in real-time data, we have a weekly meeting where every team presents out from their team their data. And their data may be how many patients they engaged, how many they graduated in a nursing program, how many saves they had on the inpatient side where they discharged patients from the ED with resources at home, monitoring, follow-up. Each team presents in real time what happened last week and what is the year to date. And so we can see if we don't continue in a certain direction immediately on a weekly basis, what happened there? Was someone on vacation? We figure that out in real time, because that's so important in that meeting that we see immediately. Or if we're not making our goal, do we need more resources? What's going on? So that's the most important. The part about the physicians and sharing data, we curate what we share. And we share it in a competitive way because physicians are competitive and they want to know, am I as good as everyone else? I'm better, And so we share like large, medium, small practices comparatively, their quality data on everyone, and then individual physicians. And then we celebrate practices for the work and their whole staff with lunches, awards, who reach the highest quality or reach certain metrics.
Yeah. And when you implemented, did physicians get excited about this competitive nature?
They do.
Yeah.
They do. They always want to be on the honor roll.
Yeah.
Right?
Love that. Love that. So now you've shared some specific examples of kind of operationally how you're using this data to manage populations. Can you share an example of an intervention or an innovation that you've introduced, what that process looked like, how you measured success, kind of an example of a tool you've implemented to really help manage populations?
Yes. So we have integrated in our EHR for our inpatient case management team to see the readmission risk score for every patient in our program. And what we do is we tell our physicians those people at the highest risk for readmission need to be seen within 7 days. So we want to work smarter, not harder, because we know primary care physicians don't have access all the time to see every person who ever went into the hospital within 7 days. So we use that predictor to, if you just see these, we'll prevent a readmission. The others we can see later. We're parsing that out. And right now, we are scheduling for the people in the hospital, about 75% of those directly before the patient leaves the hospital. They have the appointment within 7 days or less. And then what we measure is, are we preventing readmissions? So we don't tell our physician you need to see every single patient that's in the hospital, but see the ones at greatest risk.
Yeah, and you have, I'm sure, a myriad of quality metrics that you're tracking to at any given time. Mm-hmm. Is readmissions one that you're paying particularly close attention to? Mm-hmm. Yeah.
And the reason is, when you are demonstrating savings, what are the highest cost things within healthcare? It's an admission, it's a readmission, it's ED utilization, it's post-acute facilities like long-term acute facilities and rehab facilities. So you're looking for opportunities to have better care, because I think the way I look at it is, if you improve quality, the ROI follows. And the reason is, I don't think patients want to be readmitted or admitted. So if we better coordinate care with services and our teams, calling them, following them 30 days post-admission, if we do a better job at that, then they're not readmitted, and it's better care in the end.
Yeah. Well, and I think often when we're talking with companies and we're talking about readmissions, everyone's focused on the penalty, mm-hmm. right? And that's one side of it. But I think, to what you just described, if there's any risk-based contracting going on where total cost of care is an important metric, a readmission is a huge hit, mm-hmm. potentially, to mm-hmm. a total cost of care.
Yes, absolutely.
Makes complete sense. So in thinking about all this additional data that you have access to for these populations, physicians have access to the right amounts of data. As you're asking clinicians to play a larger role in managing total cost of mm-hmm. care, what do you see in terms of how that changes a physician-patient dynamic, mm-hmm. in terms of trusting their physicians, and how do the clinicians start to manage that?
Well, one way to think of this, we never want to disrupt the physician-patient relationship. That is critical. And then after that, the most important thing is improving quality. So with a patient, when we have physicians controlling total cost of care, the only things that we have implemented have to do with preventing readmissions, that type of cost, which is a better care for the patient and a patient satisfier. So it works for everyone and doesn't disrupt trust. It's something a patient wants, and not being readmitted or avoiding an admission. So we align those type of costs.
Yeah, no, that makes sense. And I think we talked a little bit about the beginning at the pace of change in terms of mm-hmm. migrating to a more value-based model. We all know that Houston is a very provider-centric mm-hmm. ecosystem. Mm-hmm. How does that impact the speed at which we move to value-based care, or does it? Who's playing the biggest role in really in furthering that transition? Hospitals, payers, employers?
That is a great question. So first, there has to be a payer contract. So I'd say, that would come first. And then someone has to be responsible for the financial risk. So in our ACO, our physicians are not, if we did poorly and had to pay back $50 million, our physicians would not be liable for that, okay? So we have a health system that's signing off with Medicare that. And then when we get to that pace of change, so what's really moving the needle, well, we have to have engaged physicians. So we engage physicians, we have a physician board for the ACO, a physician quality committee, finance and operations committee, and a physician advisory council. And I feel we have very engaged physicians. They have really great ideas. These are their patients. What works, what doesn't work. We bring to the Physician Advisory Council new technology, new things we think we want to try to get their feedback. We sometimes pilot in some of the practices. I think they control a lot of, they can definitely control the quality, but they need also the ACO team of nurses that are calling their patients when they're in the hospital, following them 30 days, the case manager at the bedside in all our hospitals, all these other components that work in collaboration so they can do their job.
And with our last few seconds, any parting words of advice for the innovators in the room who might be designing solutions to fit in a value-based care world?
Well, I'd say what an exciting time for you. What an exciting time, because there's tremendous opportunity and growth. And I would say look for opportunities in healthcare of high-cost areas that improve quality and reduce costs, which is the definition of value, and also be willing to pivot. Because we have worked with a couple of companies and piloted their technology out of the TMC, and both of them were terrific at the start, but then they pivoted where the real opportunity was to another perspective. So don't think you have this great, ride that journey, and then pivot when you say, oh no, this is where the opportunity is. But there's tremendous opportunity, particularly because of the technology. We're using AI care coordination. I'm sure AI can be used in many different ways we haven't thought of.
Well, thank you so much, Dr. Andrini. I really appreciate it.
Thank you. Thank you so much.
It was great. Thank you.
Thank you.